PK stands for pharmacokinetics, and this is the process by which a drug is absorbed and distributed and metabolized and eliminated by the body. So it relates to the drug concentration over time. Then there's pharmacodynamics, and this is the relationship between the concentration of the drug and its antimicrobial effect over time. And you can use both of these types of data to model how the drug might work in vivo. And this is an example of one of the parameters that will be used in the modeling. This is a measure of percent time over MIC. So here a drug is given where you see the dose, and the drug concentration increases in the body over time, and you see that arc, and it gradually decreases as time goes by, and then another dose is given. Well, this time above the MIC is a parameter that's useful for predicting beta-lactam activity. So this is a parameter that was looked at for both the cephalosporins and the carbapenems. What is the percent time above the MIC? And this predicts clinical outcome or clearing of the bacteria. And this parameter is analyzed in a simulation called a Monte Carlo simulation. So basically this is looking at a group of patients and asking what percentage of those patients achieve the relevant PK/PD parameter, in this case, percent time above the MIC. Now, to know what the right PK/PD parameter is, there are animal studies that are done. And in these animal studies, you look for bacterial effect. And you can either have bacterial static effect or bacterial cytal effect. And for instance, for some of these beta-lactams, you start to see bacterial cytal effect when you have 40% time above the MIC. So you would want to set your susceptible breakpoint where you have optimal antibacterial activity or bacterial cytal activity. So for many of these drugs, the 40% time above the MIC was the optimal target attainment. So this is actually a Monte Carlo simulation, and a Monte Carlo simulation occurs for a single dose of a drug. And so to pick a dose of a drug, we would pick the most common dose that would be given to a patient. And in this case for imipenem, it's 1 gram every 8 hours. And in this Monte Carlo simulation, you're analyzing the probability of target attainment at different MICs. And you'll see the line with the boxes is the 40% time above the MIC, and we said that that would be optimal in this case. Well, at the susceptible breakpoint, you would want 90% of your population or more to achieve this 40% time above the MIC. And that's where the susceptible breakpoint occurs, and that's at an MIC of 1. And then you'll see in the intermediate category, there's somewhere between 80 and 90% of the population that would achieve target attainment. And then in the resistant category, there are much fewer patients that are achieving target attainment. And so this is an example of how you would set breakpoints using PK/PD data. Now, there are a number of factors that would affect this PK/PD data, or this modeling. One is the drug dose. So I said this is specific for a single drug dose. And for the breakpoints that occur in the CLSI documents, these were set at the most common doses that would be given to patients. Drug administration can always also affect this. So for example, if a drug is given in continuous infusion as opposed to intermittent infusion, you can have different Monte Carlo simulation results. And there are also patient characteristics that can affect this, and this would result in distribution and clearance. Well, because this third characteristic is specific for the patient, it's hard to convey that information in a CLSI document. But we can convey the first 2 points in a CLSI document, and that's why for both the cephalosporin breakpoint changes and the carbapenem breakpoint changes, you'll now see information about a drug dose And you might also see a comment about differences in infusion times. So specifically, I'm going to talk a little bit about this drug infusion because this is a comment that occurs with the carbapenem breakpoints. It says that when an isolate tests intermediate, a physician may still be able to use the drug, just alter how it's being administered. Here's an example of how that occurs using these Monte Carlo simulations. So here I'm showing you basically the same data for imipenem, and up above we have intermittent infusion. So that's how the drug is given. And again, the susceptible breakpoint at 1, you have just 90% of your patients achieving target attainment, and in the intermediate category, it's between 80 and 90. Now look at that point in the intermediate category when you use continuous infusion. Now you have 100% of your patients achieving target attainment. Now this may seem like splitting hairs, but what you have to consider is a physician trying to treat a patient who is infected with a Klebsiella pneumoniae. And that Klebsiella pneumoniae is resistant to just about every drug, but it has an imipenem MIC. Let's use an example of a MIC of 2. So that's in the intermediate range. Well, a physician might still choose to use that carbapenem because he doesn't have a lot of choices here, but administer it as continuous infusion and improve the chances of therapeutic success. Now that we have these comments, these drug dosages and the infusion comments, how would you actually use those in a clinical microbiology laboratory? Well, the idea is that this is the most critical information when treatment options are very limited. And it's meant to convey information even if there's an underlying resistance mechanism. So even if an isolate's producing a carbapenemase, there still could be good therapeutic outcome with the carbapenem. So a physician might decide to use higher dose or prolonged infusion times. What I think what these drug dosages are meant to be is just an understanding at which the breakpoint is set. So I think how you would implement this in the clinical microbiology laboratory is when you're implementing the breakpoints, it would have to be done in consultation with ID physicians and with the pharmacy so that they understand where these breakpoints are set, what the drug dosage is. And if a lower drug dosage is used, then the interpretation of the breakpoints might have to change. Or if alternative infusion times can be used or a higher dosage, then an intermediate category might now seem as possible to treat with the same drug. So I want to talk a little bit about what you can expect for results if you implemented these breakpoints. So for cephalosporins, what we used to have with the old breakpoints are ESBL producing isolates that would test susceptible to extended spectrum cephalosporins. Then you would do the ESBL confirmatory test, and if that's positive, you'd report it as resistant to these drugs. With the new breakpoints, what you can expect are that ESBL producing isolates may not test resistant to all extended spectrum cephalosporins. So for example, you'll have an ESBL producer that will test susceptible to ceftazidime and resistant to ceftriaxone. What you can expect is that ESBL producing isolates will test resistant to at least one of the extended spectrum cephalosporins. So most laboratories are testing at least 2, or that's what we hope. And the drugs, so one of them would be ceftazidime, and the other one would either be ceftriaxone or cefotaxime. And resistance to ceftriaxone and cefotaxime are almost identical. So you would expect an ESBL producer to test resistant to one of those 2 drugs, but not necessarily to both. Now for the carbapenem breakpoints, things are a little different. With the old breakpoints, if you had a carbapenemase producing isolate, This isolate may test susceptible to one or more carbapenems, and these are the carbapenems: doripenem, ertapenem, imipenem, and meropenem. With the new breakpoint, you would expect carbapenemase-producing isolates to test resistant to all of the carbapenems. You might have one that it doesn't test resistant to, but really carbapenemase-producing isolates, nearly all of them will test actually it should be non-susceptible to one of these, and for sure ertapenem. Ertapenem will be your most sensitive indicator of a carbapenemase-producing isolate.